Hey guys, hey, we're live. I'm so sorry. Thank you for the wait. I'd had a few camera difficulties, but I was able to figure it out, use a different camera. But we're rolling, we're ready to go. And so I appreciate everybody coming. There's questions here, are ready to go, which is good. Maybe we're late because we're waiting for more people to get in here. And so I'm Nathan Peterson. I think you already know me. I'm a licensed clinical social worker. We're going to be answering some questions about OCD, and I thought it'd be super important to get my buddy here, Justin, to join us because he's an OCD therapist in the area as well, and he knows a lot. And so I thought it'd be good to get us both here and be answering your guys' questions today. So Justin, do you want to introduce yourself and say who you are?
Sure. So glad to be here, and also really appreciate the comments that I've seen so far. I was that little troll saying, "Hey, it's going to be one more second." So thanks for bearing with us. But yeah, I'm an OCD and anxiety specialist here in Dallas. 90% of my caseload is OCD. Just really equipped to do that deep dive like Nathan, and love the work, love the people that I get to work with every single day. So what an honor it is to be here with Nathan.
Yeah. Well, I'm so happy that you're here. And usually, one thing I say with these questions is if you can, try to put them all in kind of one block so that we can see them really well. If they're in two or three, it's hard to kind of, put them on the screen and answer them. Mm-hmm. And so I know Justin was able to see some questions here. Let me look and see what maybe we can start with. I'm just going to go.
Yeah. Great. You want me to jump in with one of the ones that I saw that I could start with easily?
Yeah, it'd be great.
Great. So Ashley Creary, I saw a clinical question, or at least I took it as a clinical question. Have you seen success with TMS for OCD? Great question. So what we have to do first and foremost, I'll answer that question directly here in a second. So first of all, we look at the evidence with this. So first of all, TMS wasn't a treatment for OCD, but then they used a specific protocol for OCD. And not everyone is yet using this protocol. It was FDA approved for OCD, I think just about 2 years ago, meaning that it's tolerable, it's suitable, it's not going to cause harm, reasonably speaking. And for some, there's some potential improvement. But if we actually look at what's recommended based on research and effectiveness for the most amount of people, with any treatment, of course, we're working averages, and so we have to personalize it to the person. Generally speaking, we want to try several things before we get to TMS. Now, you're not asking that, I realize, but I wanted to offer that initial upfront mention because when we say, have you seen success? My small sample size in my practice of people who've actually done the dedicated protocol, because some haven't or have done just like really short 1 week of sessions, which is not going to do it, haven't honestly seen a lot of success in the 3-4 instances since 2 years ago, once it was FDA cleared. But evidence shows that it does help for some people, but it's typically going to be about a third line recommendation after multiple other things have been tried. So I hope that helps.
Yeah, I like that. Just to kind of echo something you said, I usually see, I guess if TMS worked, I probably wouldn't see the person or hear about it if it did or didn't, because they wouldn't be coming to therapy. Yeah. And so I do notice that they're still doing ERP therapy and maybe defining what does success actually look like for the person as well. Maybe it's reduced thoughts, I don't know, but medically wise, I'm kind of with you, Justin. I haven't seen too much success with it, more than them just doing, ERP, but I'm sure there's research that's currently being developed that they'll figure out if this is really effective or not.
Yeah, that's right.
Yeah. I like this one here. I mean, I like all of them, but this one's great. So, how can we prevent?
Come on, Nate. I know. There's other people on here.
I know. How can I prevent relapsing while going through ERP? It's tough to stay consistent at times. Yeah. This is really hard because we know when somebody is doing exposure and response prevention that it becomes a lifestyle, something you do not just while you're in therapy and then you're done, you're golden for life. It's something you do actually for life. Maybe not the intensity that you're doing in treatment, but to prevent relapsing is to find something that works for you to remind yourself that, either it's old topics that you've worked on or new topics, that you do something every single day to remind yourself that you still got it. I remember Shala Nicely, one thing that I remember her saying is that she sits on the floor, I believe if I got the story right, and she eats her breakfast every single morning to remind herself that contamination isn't a thing for her anymore. And if she ever has the thought of contamination, she pushes some food on the ground and eats it. And she doesn't have to do that because it's not a problem anymore, but she chooses to do that to remind herself that I'm not going to relapse because I'm willing to engage with it before it finds me, essentially. We know relapse is very common though with ERP, so it's hopefully not being hard on yourself if you do relapse. I always say learn from each experience that you go through. That if there is a relapse, we kind of look back and say, oh, okay, well, what can I do differently? What compulsions kind of got me here? And maybe which ones do I need to reduce to get me back to where I'm at? So to know that all hope isn't gone if you did relapse, because everyone's probably going to do it realistically. Anything to add there, Justin?
Yeah, so one of those just hands-on tools that I'll oftentimes use in a couple of ways, motivational interviewing and acceptance and commitment therapy are a couple of tools that I'll use. Part of staying consistent with anything, brushing our teeth, flossing. I'm teaching my little girl to do that now. It's wild to have a little child flossing their teeth. It is so, and even just other daily things, sometimes emails for me, just keeping up. So how do we get consistent with anything that we don't want to do? I mean, beyond just ERP, as Nate was talking about, the lifestyle of this. So one, what is our buy-in? What are our motivations? What are the things that we connect to as far as the reason behind? And when we think of something like an exposure to just touch that item on the floor, it might not seem like it connects very deeply to our values or whatever else until it does, until we see that, okay, if I go ahead and touch this item on the floor, this is connected directly and also indirectly to my freedom and my ability to stay recovered. So that's one big thing. And then the flip side of that too is, and this is borrowed from the recovery literature in drugs and alcohol, having something along the lines of consequences, inventory, or in nicer terms, what bad things happen, right, when OCD is out of control. So if we understand both our values and then secondarily what happens if we stray from them, it can help give us a clearer picture and a little bit more buy-in. So those are just a couple of practical things that I like to mention.
Mm-hmm. Yeah, thank you so much, Justin. All right, I'm going to pull another one up here. And you're welcome to answer this, Justin, or I can. I'll read it here. I have a fear that taking my antidepressant will somehow make me act on my OCD thoughts. Is this normal? As if these thoughts and things are I actually want and not OCD. And so at least my own experience real quick is I see this actually be a really common fear for a lot of people, that if they start taking a medication which possibly they feel like might inhibit their, if I don't feel anxious about it, essentially, then what if I actually act on this? Some might feel like the anxiety is the thing that's been keeping them safe the whole time. So if I don't have it, I might actually act on it. One thing that I've seen is that definitely a common fear, but we always say trust in the treatment, trust in the prescriber. If they say a medication is right for you, often people actually will do exposure and response prevention with this as well and say, medication may or may not make me act upon my thoughts, may or may not make me act upon my thoughts. That we're living uncertain on purpose throughout life, through every aspect, to say trusting in the treatment might be right, might be wrong, I don't know. And to know that thoughts are thoughts, and I just kind of reiterate trust in the prescribers and the therapists.
Yeah, and I think a great way practically to do that as well is to do what is normally prescribed, if you will, by the physician who is prescribing. So if you're meeting at a certain frequency and they follow up and ask you about symptoms and ask you if there's anything else, there's an appropriate place to say, hey, I have observed fill in the blank. Now, if you're working with ERP therapists or trying to do ERP, you might also spot repetitive reassurance-based questions. And of course, those have to be addressed from the OCD standpoint. But if you give yourself that framework of, okay, well, I'll let myself ask these questions in this context, it can really help couch any potential compulsions in a place where you'd normatively ask an appropriate question and to actually trust in that process and to lean into that uncertainty.
Mm-hmm. Yeah. And at the same time, nothing's going to be perfect. Sometimes we make mistakes. I think that's the whole idea is we're just going to live life and focus on our values. And that's really what's most important.
Mm-hmm. Mm-hmm. Yep. Yeah, that's right.
This is one I haven't talked about too much, but I have POCD, working on getting a therapist at the moment. Took me a while to figure out what ATM meant. I'm always like, hey, getting some money out, or and recently I've been dwelling on past memories and uncovering scary things that could maybe confirm my worst fears. So help. POCD definitely likes to join the party with some past memories or even some false memories from the past. And if you're getting a therapist, say find somebody that obviously is I don't know if you can hear my child, is an actual therapist that specializes in OCD. Usually we say iocdf.org is a great place to find somebody. When it comes to POCD, I guess the question is help. So how would we help somebody that is struggling with POCD, Justin? Just throw you in there.
Yeah, definitely help. It sounds like it's just any help maybe at this point, or I'm reading this as kind of a broad thing. So I mean, first of all, when you're asking for help and maybe not one specific point, I just wonder, if there's a lot of suffering going on right now, Megan, and just want to validate that here you are tonight, you're showing up, you're referencing something that can be really scary to talk about. And can I say that we both are proud of you for doing that? Yeah, awesome. Don't want to put words in Nate's mouth, but first of all, that's a big deal, really, really big deal. So part of the help with these things starts out, as some appropriate validation as well. We don't give reassurance in this business, but we do sure like to give a certain amount of assurance and validation. So that's really hard. When we experience fear in a strong way, or scary thoughts or memories, that is tough. And so with it, I mean, there's a number of things, but I'm going to come back to the realities of the treatments that exist. So if you have POCD, then what do you do? And have you tried some things before? Are they going well, not going well? Feel free to follow up with some of these things a little bit more in the comments if you'd like. But OCD treatment is still ERP as the default treatment. It's the gold standard to try first. So as far as those scary things and the fear of confirmation of worst fears, we ultimately are going to identify what are my behaviors and mental responses, what's causing problems for me. And we're always going to eliminate the pathological responses. And so no matter what, people will get confused about, well, this and this, and I thought I felt something, and what if I had this memory, and so on and so forth. Well, there's a simplicity a lot of times with what we do. We're getting rid of pathological responses, and we don't have to have all the answers to do that. We can start to spot the clinical side to say, basically the disease-based responses or disorder-based responses with that. And so starting simplistically is really, really huge. If you're not getting help treatment-wise, that's huge. And I'll do a plug as well. Nate hasn't asked me to do this. This is not why I'm here. But Nate's course is really good. I've dug into it, looked at it. I don't like to pass on things that I haven't overviewed. And it's just really good stuff. So that's always an option.
Mm-hmm. Yeah. Well, and thank you, Justin. I'd reiterate, Megan, seeing a therapist, it can be a tough topic to talk about. And a lot of people are like, my therapist is going to judge me, or they're going to maybe not understand. But if you get a real OCD specialist, I say be open. Tell them everything. Because they can't help you if you don't tell them. And do it quickly. Because it's something that anticipation seems to be worse than the actual thing. And so a topic like this, definitely, we try to be as open as we can. I have Tourette's, so comorbid with OCD, so connected. It went away for a long while, but it has come back as I've been under a lot of stress. How do I deal with minor embarrassment of having tics as an adult? This can be really, really, really tough. Luckily, we're in a day and age where it's becoming more talked about. We're seeing it on TV, and we're seeing it different places, and people are making TikToks about it, all these different things. Embarrassment of having tics, usually I say embrace it, which I know is easier said than done. But we embrace it and say it's actually part of who you are, what you're going through, what you're struggling with. And the more that somebody tries to change that, you can definitely try treatment if you haven't done that. But we say if a tic happens in public and somebody notices there's some embarrassment, sometimes people will play it off. They'll kind of joke around. I've seen some who have little pins or buttons on their shirts that say, hey, be patient with me, I have Tourette's. People make those. You can find them on Etsy. And it's really just letting that be part of who you are and your story, and accepting and embracing. Because I think that's when someone really feels free, is like, I'm going to do tics. I'm going to say things out loud. They can be really embarrassing. And finding a good way that works for you, where you can explain that to people and kind of just accept that, like, yeah, it might happen in public, it might not. I think leaving that uncertainty there can really help.
One thing I wanted to call attention to, I'm seeing in the comments that someone asked a question that really connects with this. Sophia Roke, R-O-K-K-E, what is the difference between tics and compulsions? So while Nate actually pulls that up, that's a really good question. I wanted to get that going. And actually, let me respond to the last one first of all, too, that I think it says a lot, Mr. Guyman, about your strength, that you're saying minor embarrassment, right? So you're not saying that that's debilitating, which it can be for some. And so that's a really, really big deal. And it's also treatable as well. So there are really effective treatments for Tourette's, tics, and strategies to learn. Nate, what do you think about the difference between tics and compulsions? Can you delineate that one?
Yeah, I usually say it's a tic if it happens very automatically, just throughout the day, possibly no stress, it's just kind of happening. A compulsion, when it's almost like an urge to do it. You're feeling it, and there's a lot of relief when it's done. I know a lot of those can overlap, definitely, but if it's a compulsion, that means that the brain says, hey, if you do this action, whatever it is, you'll feel better. So it's almost kind of it's a compulsion. I feel better when I do this action. And usually we say, well, if you have control, let's not do that and see if you have control over that. That's usually what a compulsion in my mind would be. If it's a tic, we say hold that back, and it's not going to work as well, because we can't really hold back a tic. We can do what's called a competing response, which is a whole separate treatment than ERP. And so, yeah, the treatment for that is the Comprehensive Behavioral Intervention for Tics. Did I say that right? CBIT.
CBIT.
So look it up if you want to do it.
Yeah.
It's fine. You made me scroll all the way down now. I lost my spot. All right. A lot of people saying hi. I don't know if that's to us or for others.
Hey, what's up? Looks like some of y'all know each other. That's great. I love that there's a community built here.
This channel helps with my OCD. I love it. I appreciate it. And where am I here? Okay. Wow. So I realized I've had some kind of OCD since 5th grade today. So, and I think I saw another comment there, 19. So, wow. To find out that you have OCD and be here is actually really amazing. I think, what is the average? 14 to 17 years before someone actually finds true, real treatment for their OCD. And so I'm so glad that we have this opportunity to be able to speak more about this so you can find it. I appreciate you being open about what you're going through. I don't know if you want to answer this, Justin. Can HOCD, so sexual orientation OCD or homosexual OCD, cause false attraction?
Yeah, no, it's as with all things causal questions, and I've seen quite a few in the comments here, does something cause something else? On the scientific side, for being honest, we have very, very few direct cause effects. We know this exactly, and we have an easy answer. And frankly, when we look at most of medical science as well, there's still plenty of correlations. Even the treatment of heart disease itself seems like we know a lot, but that cause piece. So I looked at that and just always want to give that somewhat scientific disclaimer with that. So folks, when they're suffering with HOCD or SOOCD, we'll ask all sorts of questions about what does this mean? What does this look like? Am I attracted to someone? That may test those things out. Really, really pay attention to their feelings. And there's that compulsive nature to it. And so, frankly, I don't know. Can it cause false attraction? I don't know. But we come back to that values piece. I see a lot of questions here. How do you determine this whole category of sexual orientation? Okay, well, you might need to sit down, maybe not, with someone. If you look at it and say, you know what, I actually believe I have real confusion, and so it's my value to set this straight. Or people around me have always said, hey, here's some observations, but many times in OCD, it's quite the opposite. People have said, hey, you've actually been really consistent with this, ... So, but you're bringing this up anew, or why are you fearful of this? Can it cause false attraction? Maybe, I don't know. But what we have to end up facing and leaning into would be back to what we look at from a value standpoint.
Yeah, I like that you threw in the maybe not. People make fun of me for saying that so much, but
yes, yeah.
When it comes to HOCD, I'm going to throw this other one up as well. Or sexual orientation OCD, it definitely messes with emotions and feelings. And really what it all comes down to is that when people, it's a question that the brain asks, and you look for, what's the motivation why I'm asking this right now? Am I just genuinely curious? Or am I trying to seek possibly I think I have some false attraction, or I think I have this emotion, so I want to know if this is true, or if this is really me, or if this is really OCD. And we really say, if it's the motivation to know if you have one or the other, we usually say the answer is maybe not. If it's just, I'm just genuinely curious, but I don't care, I could find out next week and it'd still be fine, then we say, cool, ask ahead. But most of the time, at least a therapist will say, maybe, maybe not, I don't know. And it's actually committing to that kind of answer to say, it's okay not to know. We treat it as OCD. If there's anxiety, we're just, we might be wrong, we might be right.
Yeah, emotions as well. Fear and anxiety typically are linked with OCD, but OCD is not just a disorder of fear and anxiety. In fact, man, if I'm just way too nerdy for your channel, Nate, you just let me know. And y'all, if you never see
how do I get you off here?
You'll know. You'll know what happened. But when our manual that we use to diagnose disorders, DSM-5, came out in 2013, they moved OCD from anxiety disorders broadly to its own category. And one of the big reasons that it deserves its own category is it's not just an anxiety disorder. It's an anxiety, shame, guilt, loneliness, sadness disorder, where any sort of emotion can be implicated in OCD, and especially those stronger, just deeper emotions that we feel. So I've actually changed my rating scale with some folks. We use oftentimes what's called the SOOCD scale. It's like the pain scale in hospitals, 0 to 10, how much distress are you feeling? And a lot of people just say anxiety, right? Or for me, most of my clients will say fear, anxiety, but sometimes it's shame. I changed it with one client to say, how much shame are you feeling? At least for a little bit. And simple answer is yes, 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 yes. And did I say yes?
I like that. Kind of separate shame, distress, anxiety, that all of it's uncomfortable, but being able to rank whatever it is for you.
Yeah. Oh, and one other thing, this is a huge kick that many of us in the community have been on, this piece that OCD is OCD is OCD, which is true. And we can get too distracted by various subtypes and themes, so we don't treat it effectively. But we can also go the other way of not being sensitive towards the individual's experiences. And if, because of sexual orientation OCD or pedophile OCD or fill in the blank, if you're more filled with shame than just the frustration of something else, not to say that you wouldn't experience shame, but I find most folks struggling with contamination OCD aren't at least front door talking about shame. They might feel shame that they haven't reached their goals or been where they are, but not as much directly associated with it. But when we deal with a lot of the intrusive thoughts, unacceptable thoughts, as they're sometimes called, it just makes sense face value that shame, for example, is going to be one. And you've said emotions in general, but it can be guilt, sadness, as I mentioned. So anyway.
Yeah, thank you so much. What is anxiety about death? That's a big question. I'm trying to think of like what topic this would fall into. Usually existential OCD is one that I would see that fall into, or thinking about what's the point of life, what's happening after this life. Usually, sometimes it can just be a anxiety. Anxiety of the unknown, something we don't know just yet. The brain has to come up with all the ideas about it, and unless you have a specific, I don't know the technical term. Is there a technical term for anxiety about death?
Not that I know of. I guess there's a couple of different categories. There's anxiety, in our core fear understanding of different obsessions. Of course, one of the core fears is this is going to kill me. Get sick and die is one of the most common phrases that I'll hear with contamination OCD. In fact, clients don't even realize it, but they're oftentimes exact quoting other clients that I have in my practice because it's just such a pertinence core fear. And so there's that side, more the, could I die from this soon or someday later in a way that I could have prevented? But then also there is that more existential category. So if you're talking about that, generally that would be the more existential philosophical.
Nice. I don't want to feel like I'm advertising or anything, but the online course therapy. So it's not therapy. It's an educational course, but it does take you through exposures, understanding your OCD, and how to maintain progress. Talks about medication, things like that. But can't be a treatment course, kind of ethically, but definitely takes you through what you need to know. A lot of people take it while they're seeing a therapist as well, or they're waiting on a waiting list. I feel depressed when the thoughts tone down, and I'm not sure why. I don't know about you, Justin, but man, I see this a lot. It's very common. My theory is that anxiety and OCD kind of are head to head. Sometimes OCD is up here. Whoop. And as we start reducing those symptoms of OCD, depression doesn't follow. It just stays. And all of a sudden people are like, I'm kind of feeling some depression. And because we worked on the OCD so much, sometimes that can reduce because the hopelessness kind of goes down. But I kind of find that lingering depression there. And usually that's because people are thinking about the things they've lost throughout their life. What have I lost the last 17 years going through this OCD? And now I feel a lot better, and I can't believe I didn't do this sooner, kind of thing. Sometimes depression is just depression, and we can often treat those together. And so I use behavioral activation for something like that, where we change our behaviors every single day, do something brand new sometimes that you've never even done before, and do it with meaning and power. Because a lot of times people are like, I have to go on a walk because someone told me to go on a walk. But if you're like, I'm going on a walk and I'm going to notice 5 sounds that I've never noticed before, and I'm going to touch the leaves as I'm walking by, and I'm going to think about 3 things I'm grateful for while I'm out here, it's going to be such a better experience. That this is often one task that we do for depression, is like, do something new, get out of the routine. Because if we feel depressed doing the same thing we do every day, then we're going to probably feel depressed doing the same thing we do every day. It's got to be different.
Yeah, a lot of clients that I work with OCD and anxiety as well are terrified of quiet moments. So many times clients will talk about just the really busy brain. And so when slowing down, it oftentimes offers a great option to slow down, right? And maybe notice some new thoughts or other things. And as Nate's talking about, kind of left with that depression. And also want to comment on the concept of homeostasis, that any organism that is activated by fear, when the fear ceases, our bodies as a human being don't just all of a sudden come back to the middle of the pendulum. So this pendulum swing of facing a fear or sadness or guilt or whatever, we're not just like, boop, homeostasis, we swing to the other side. And this is something you can actually look up from reputable places, unless if that's a compulsion, then don't. But the homeostasis is basically your brain turning down a party that's gotten way too loud. And so depression is very, very common, and there's a lot of just technical details, many that are way beyond me, of what's happening in your brain at that point.
Yeah, thank you. Let's see here. There's some questions about kind of some medical advice. That's kind of tough for us to kind of give some medical advice since we're not, medical doctors. But, we always say if there's someone's in crisis, you're talking about medications, we always say, like, talk to a prescriber or a medical doctor. They're definitely are going to be the ones that help you at least with the physical side, and we're really good with the mental side.
Yeah, and actually one tip with that as well, you can ask medical questions and get them answered. Some great ways to do that would be through the International OCD Foundation's various broadcasts. As part of their scientific advisory board, they'll have Dr. Michael Janicki. He's written awesome stuff out there up at Harvard, and he's done some live broadcasts here and there. Great way to connect. Many times local conferences, which by the way, these days are all virtual. Southern California's OCD conference coming up in about a month. OCD Texas has lunch and learns. ultimately there are a lot of times places now that they're virtual that you could potentially find one here really quick where a medical doctor is speaking. Just like OCD Texas, the last one we had live, we had one of our experts in OCD talking on medication. So FYI, even though we can't answer that, and we're going to give you that little dodgy, like, hey, we're not a medical provider, we can't answer that. Like, there are appropriate ways to ask it if you are having a hard time maybe getting into somebody or affording or whatever else.
Yeah, awesome. I have false memory OCD. Can I have false memories about real events? Totally. There's your answer. Next question. Just kidding. Totally. It definitely loves to take real events and say, I wonder if it happened this way, or I wonder if, do you remember if your legs were over this way, or do you remember if your hand touched, whatever it is. It takes real events and throws a lot of doubt and false memories into that. But we also don't use that for reassurance as well. Let me say, if there's something that you're ruminating about, you keep thinking, and you're like, I'm not sure if this is false or not. You go back to that default, maybe it happened that way, maybe it didn't, maybe not.
Nate, what are some of the tools that you use for the living uncertain? So I'm going to call you out. You use it as a tagline, my friend. So, or not a tagline. You say it oftentimes. And all of us do, really, in this community. So what are some of those like strategic ways that you'll use sometimes facing uncertainty?
Facing uncertainty. I seriously use it every aspect of life, whether it's OCD, whether it's anxiety, that if it's not something I really need to know, I choose to not know.
On a need-to-know basis.
It's really a need-to-know basis. Any what if in the future, do we really need to know? Like, there's some that are pretty obvious, but we don't have to question that. I think that's the thing I look at is, if I have to keep questioning, if I need to know something, I probably don't need to know it. But if it's like, when's my wedding day? I should probably know that. Like, there's some what ifs that are really important. Staying uncertain, I use an equation of, I think I've said this before, like, if you're feeling anxious and it's plus, you don't see immediate danger, we're choosing to stay uncertain about it. If you see immediate danger, you're going to take action. You're going to fix it. You're going to get out of the fire, whatever it is. Especially when it comes to OCD, that's the equation I use. Sometimes we could be wrong with the equation. I think that's the risk. But be willing. I have people be willing to take that, because we're going to find that 99% of the time we're good. It worked out.
I really like that. So you're actually developing an approach or helping people develop that lifestyle approach, as opposed to any one like specific, which none of us have, just this home run specific that knocks the ball out of the park anyway. So I really like that, Nate.
Thank you. I'm going to read this for you. Unless you want to read it, Justin.
Oh, okay. I have POCD with sexual intrusive images, and sometimes the what if I want to do this question comes to mind. Does the maybe not answer work with this?
I thought this was important because I want other people to see that you are not alone in having these intrusive sexual images. It's super common, especially the what if I do this. And for me, I say maybe not still applies. Because we treat OCD, we're not treating the topic. And that's what I look at is, what do I need to do to react differently or respond differently to the thought? To just really say, essentially, like, how can I disregard this thought without pushing it away or distracting? Like, okay, cool, thanks for the thought. All right. That's some of the dialogue that I use as well. Other than maybe not, is like, okay, cool thought, you can stay if you want, maybe not, like, I don't care. Just to take that power away. A lot of people feel like my topic is different or my theme is different, I can't apply this, whatever I'm learning to it. But what I find is it really does, the whole concept is how can I be more uncertain about whatever the thought or fear or question is. And so people can find different things that work. Some people might not use maybe not. They'll use something else that, how can I not answer this what if right now? And you find whatever works for you. So a lot of times it's not doing the compulsion is really what it is. If I'm trying not to seek for that reassurance, or I'm not researching, or I'm not avoiding, then my body's already doing the maybe not. You're risking it by saying, we'll see what happens at the end of it all.
Why do we want to live more uncertain? It's an odd concept and it seems paradoxical. What would you say about that, Nate?
Man, big questions here. There's more freedom in just being uncertain. There's something, I'm going to credit my brother here. He used to say a lot, we're only afraid of what we think we know. And I'm like, it makes a lot of sense that we think we know so much. And it's the stuff we think we know that we're trying to answer, that we're trying to stay certain with, that we can't really be certain with. And so to maybe not even risk getting stuck in an anxiety moment, that's where I say, just be uncertain. Choose to not figure it out on purpose. Whether you could or not, and it didn't cause any harm to your anxiety or whatever, or OCD, I feel like there's so much more freedom in just saying, I'm going to focus on my family because I care about my family, or my religion, or whatever is meaningful to you, other than trying to figure out whatever the what if is.
Thanks, Nate. Appreciate that.
Let me see here.
One comment while Nate's looking at that too is that effective treatments is based on strong assessment. And Nate and I are going to launch a video this coming week, so we talk about this a little bit in there. So be on the lookout, first of all. But we use this fancy term called functional assessment or functional analysis in behavioral terms, where we're looking at the interrelated parts of different things. And we have to look at the individual person. For some, they could develop maybe not as a compulsion, right? Like, I have to say this now in order for OCD to be better. It's like, okay, we look at the flavor of it. We look at the nature of how that person is approaching it. And so that's why we say that this is education, because personalized to the individual, there's just those different nuances. So hopefully we can educate you well enough to be able to spot some of those things and say, okay, what is the fear that I'm facing, or the shame that I'm facing, or the guilt that I'm facing, and what is the way that I'm going to decrease, minimize, block, not block, maybe accept, but decrease, minimize the compulsion, and ultimately eliminates the compulsion. It's really, really simple, so hard to do, and it's not always easy to understand. But when we boil it down to the simplicity of what we're doing, it's a pretty simple thing. But I think all the best things in life are. Just like any other practices or disciplines that we believe are good, it's not necessarily that it's out of reach from the mind of even a child, right? But it's so hard to do things that that help us to live out those valued behaviors and beliefs.
Awesome. Well, I already pulled this other question up. Do you know any treatments for religious OCD? Well, treatment for all OCD is exposure and response prevention. I don't know if you want specifics, but depending on the specific topic or fear, usually it's the same thing. How can we be more uncertain? All religious beliefs, we're all hoping and having faith, which, that's why OCD loves it. Because it's like, how can I make you doubt something that you're having faith over that you don't know for sure? Like, that is OCD, trying to take someone's value and destroy it or exploit it in some way. But treatments for, get back to simple treatments for religious OCD, exposure and response prevention. Do the things that you want to do. You want to go to church, you go to church. You want to pray, you pray. You don't want to pray, you don't pray. You do the things you want to do, not things you feel like you have to do, because if you don't, you're going to feel anxious. So I usually take a step back and say, do what you want to do, what your value system is. Let the uncertainties be there, because that's what religion, a lot of religion is about, is the uncertainties, and we don't need to know it all. That's what faith is all about. Jumping into this one, I can answer this. You can also do it, Justin. But is it possible to have someone with a sexual orientation OCD actually have a same-sex experience? I already read it, so I know the question. I know some answers, but I've seen it. I've seen sexual orientation OCD start because somebody had a same-sex experience, and then made him kind of question with that. I've seen some people experiment to test out their theory, which is a compulsion, and so definitely possible. Yeah, but we, at the same time, we don't have to always know 100%. Like, if we know someone has OCD, we treat it as OCD.
Yeah, spot on.
All right. Someone said, stop asking for reassurance, people. It does no good. It's hard not to.
One comment too is that it's in OCD so easy to want to test whether something is true or not by running it through any number of usually non-scientific tests or even just getting away from science, things that don't even fit what the person on a good day would say for them would be a suitable test. So, I mean, let's take the example of relationship OCD, which can play on some similar themes at times. A person can fall into the compulsion of asking certain questions or tests, or having even sometimes mystical or magical superstitious type things, like, okay, you know what, during this conversation, I'm going to pay attention to how much they make eye contact with me. And if they don't make eye contact more than half of the time, they must be shady or whatever else. And it's almost like some sort of a quiz at a Cosmopolitan or something that has no basis in what might be true for that situation for you or the population as a whole. So with it, we can always be looking for these ways to test it, but is it compulsive? Does that actually fit the situation? So experiences don't necessarily tell us a lot per se. People are constantly wanting to test based on relationship or sex or thoughts or whatever else, like a bigger picture. What does this mean? And there's a lot of compulsive ways to do that, but then there's also the freedom of not getting stuck in the compulsion with that.
Thank you. How do you distinguish OCD with poor insight from OCPD? And so OCPD, obsessive compulsive personality disorder. Do you know? You want to answer this?
Yeah. So, I mean, OCD and OCPD are actually quite different, despite the fact that they share a lot of common descriptions. How it's approached makes all the difference. And this is why we look at assessment on our side of things. So obsessive compulsive personality disorder involves rigidity and inflexibility in patterns, routines, and some of the overt behaviors can look like OCD. So a person may want something to be organized or arranged or clean in a certain way. But if you spent any time on Nate's channel, you've probably picked up the fact that just because it looks neat and tidy, that's the colloquial, actually inappropriate reference to having OCD, because it's not about being neat and tidy and ordered. And so OCPD is particularly when there's this rigid inflexibility, and it has to be for a very consistent period of time. It's thought to not to be more trait-based for the personality. And so it's more resistant as well to change, harder to change. So OCD with poor insight, it's a good question. It just takes more assessment, and it helps to have more history. For example, I mean, some of the questions that clinicians are going to ask, of course, the person themselves, which if it's only one person, it does make it a little trickier. But if a spouse is coming in for a session, typically it's not diagnosed until a person's an adult. But even if it's kind of later adolescence, getting ideas from multiple people, or if the client is shooting straight about those things, we're going to separate out consistent patterns and inflexibility versus more sporadic or passing low insight. So OCD with poor insight can look very similar, but if that person starts to respond as well to OCD treatments, that can be a clue that, okay, this is maybe helpful, and that's where we don't want to come into therapy automatically experimental, but sometimes in the question when it's an I don't know, a person can say, well, would you be willing to try this therapy? If it's possible that you have OCD, if you do this therapy, it's also very possible that you can get better. And if a person's willing to try that with a high likelihood that it's OCD, then it's up to the individual clinician. There can be the appropriate way of doing that. If their insight improves, great. You might discover more easily that was OCD.
Mm-hmm. Thank you, Justin.
Mm-hmm.
Awesome.
Yeah.
I usually think of OCPD. People tend to like their obsessions, or they like the things they're doing. OCD is more ego dystonic. They don't like the things that they're doing. That's one big distinction that I look for.
Keeping it simple.
Keeping it simple.
That's right.
I'm not sure how much time we have here, but I'll answer these super quick because a few people asked for this one. Can the theme of OCD be caused by a fetish? Probably. I think if OCD, well, I don't know caused. I think it can bring on a topic because what causes OCD? Genetics, we know, is possibly a big part of OCD, but there's not going to be that one defining like, oh, this fetish caused my OCD, or I watched this movie and that caused my OCD. It's actually like if you have OCD, you had OCD. Something that people have. There can be those big moments that bring it out, but it didn't necessarily cause the OCD. It just kind of said, hey, I'm going to put a lot of value on this topic or theme right now because this is something you really value. So it really can confuse people to like, oh no, this caused it, but really maybe it's just a catalyst to what you're going through.
Mm-hmm.
Oh, I like that. Okay. In ERP, what does response mean? I understand the exposure part, but what is the response part? So I had this exact same question when I was learning about this. I knew about the exposures, and I was like, man, we just gotta have people face their fears, and it's really hard. It's really easy to forget about the response part. That's actually probably the most important part of this whole thing. You can expose yourself and get contaminated by touching something or whatever it is, but if you're not responding appropriately, you're just kind of causing trauma, essentially. Like, I am just going to expose myself just to expose myself and be anxious.
Yep.
The response part is, how can I retrain my brain to see this threat that it just gave me and show it that it's not a threat, but not by the compulsions, to actually probably do a test that my brain says, one thing I think about is if a fire alarm were going off, most of the time people don't just jump out their window immediately because they hear a fire alarm. We've been trained over time to just kind of mosey around like, is everything okay? I wonder what's going on. And we do that because we found majority of the time there isn't a fire. But if there was a fire every single time, we would be that person that jumps out the window. And so that is kind of the response part. Our brain naturally learned to respond kind of like the, is there a fire? Because we had those experiences over and over and over.
Yeah.
And so when we're doing these exposures, I think of that at the same time. How can I respond as if this threat really has no meaning? And then it naturally will start doing that to say, there's the maybe, maybe nots, there's the not doing the compulsions, that's the response part. Sometimes I say smile. Smile about something that you feel like you shouldn't be smiling about. Like I'm touching this thing, it's so dirty and it's so great, and I have it on my face, and oh man, this is awesome, and I love it, and I hope it gets me sick. And like that's kind of the response part. Even if I feel like I'm a total liar, I'm responding totally different to it. And the brain's like, what are you doing? I told you you're in danger. Why are you doing that? And that's how it's learning, is like, I'm going to show you how much you're a liar. I'm willing to risk it.
Is that why you're smiling with me all the time, Nate?
My nickname when I was younger was Smiley. No joke.
Yeah.
People called me Smiley.
That's great.
It's just what happens. Can't stop.
One other comment too. Response can be interchangeable with ritual. In fact, back in the 80s and 90s, when it was really being developed, EX/RP, exposure and ritual prevention, by and large, naming kind of changed a little bit. I'm glad they renamed it to response, because a lot of times ritual is, it seems like one specific thing, and response can be any number of rituals, compulsions, mental, physical. So, yeah.
Mm-hmm. All right, Justin, do you have much time left?
I
We're
can be
getting
more.
close
I can
to
be
the
a few
end.
minutes. Head on home to the family here in a moment, but yeah.
I can get manipulative when I'm seeking reassurance from somebody who won't give it to me. My friend has started to comment on those manipulation tactics. Any advice? How can I stop it? Is this normal? This is really tough, because I totally don't blame you for wanting that reassurance for whatever it is. That's what the body is urging you to do. It wants you to seek that relief. And usually I have people with their loved ones, their friends, their family, have a conversation and say, hopefully, this is what I'm working on with treatment. I'm not going to ask you anymore if this is contaminated or not, as an example. And so when everyone's on board with that conversation, it's so much better than just a friend saying, not doing it. That you've got to be on board as well with, if they don't answer that question, that's an indication to me that I need to do some treatment with it. Because guess what? It's actually harder for them to not give you that answer than it is for them to give you the answer, which means that they're probably a pretty good friend to do that. It would be my assumption, because it's so much easier to say, you're good, wash your hands, not that big of a deal. It gets that conversation stop. You can stop it in that moment. And so, for both people, whether it's a friend or a loved one, have that conversation of, how can I help you, and maybe not give you this answer anymore. And this is what can you do instead? What's the exposure that you can do in that specific moment? It's really hard not to seek that reassurance, but a lot of times when that what if is in there and you feel that urge to do it, we might say, remove yourself from the moment and be okay with the uncertainty of, like, answer it with a maybe, maybe not. I don't know. Could be, maybe not. We'll see.
Yeah, that's really good. And I think that's really neat that you have the insight to ask that. That's huge. And the honesty to bring up that question, Beth. So yeah. Anytime something feels like it's blowing up for us, whatever it is, and we feel like we need that answer, we want that answer, it's most natural to drive for that. But when it turns out to be something that's more compulsive, it can obviously create problems, and people can manipulate, etc. And so that simple answer, the faster you can get the good treatment is great. But also, in the meanwhile, while people are even in the middle of exposure and response prevention, for example, they may struggle with the regulation of their emotions. And so finding ways in the moment to down-regulate or regulates those emotions can be really key. Nate just hit on one of those, being able to take a step away. And even though we'll talk about, of course, avoidance as a compulsion, we'll talk about sometimes even deep breathing as a compulsion to escape uncomfortable feelings. There are also appropriate times when it's rush into that 8, 9, 10 distress, a person's in crisis, really, if they don't have the tools to be able to respond to it. And so being able to down-regulate that at the moment so that you can move back from a limbic system thinking of the brain more to your executive functioning is particularly helpful.
Mm-hmm. Yeah, we're coming to the last few questions here. What should I do if my therapist and psychiatrist say I don't have Schizo OCD theme, but just anxiety and maybe hypochondria? Man, that's a tough one, because I know people want the diagnosis. They want to know what is going on with them. I would say if it's not an OCD specialist, I would say see an OCD specialist. Maybe they can give you a really good, accurate diagnosis. If it is accurate, if it is an OCD specialist, I might trust it. Yeah. Sometimes that's all we can do in the moment. But guess what? Either way, the treatment's the same. We can do exposure and response prevention for just anxiety, the fear possibly of going crazy. Treat it the same. Doesn't matter if it's OCD or not, or even if it's hypochondria. If you think that that's a fear that's happening, treat it the same. Choose to not figure it out, sometimes on purpose. We might just go with that, choosing to not figure it out. How can I move closer to some fears or some worries without doing the compulsion? That would be kind of my answer for you. So, I saw one here. I know this isn't this is probably a question for everybody, but anyone here also had facial or body dysmorphia as well as suffering OCD intrusive thoughts? What do you think, Justin?
Yeah, the commonality, I don't know of the occurrence statistically right now, but it's commonly comorbid, and particularly body dysmorphic disorder. So if you're just saying facial or body dysmorphia, that could just be, you're using some clinical terms there, but it could be a subclinical thing. So just like a lot of folks with OCD may struggle with social anxiety, doesn't mean that they have social anxiety disorder. So but it's very, very common. So to obsess on a specific feature of the body, like the face, for example, or muscles, too big, too small, or other places. And those can go hand in hand. Sometimes they can be very much a part of OCD, sometimes very much a part of body dysmorphia as well. And there are some similar treatments. There's a few things that are a little bit different with the dysmorphia and some tools that you can use if it's just kind of the subclinical, even some of the workbooks on BDD as well. But either way, yeah, they're common, and there's help and hope.
Thank you. I've got a Hellstorm going on. Do you have that as well, Justin?
What?
Yeah.
Not
You hear
yet.
those like bangs against the window? That's wonderful. May or may not be in danger. How about we do this as the last question? Is that all right? How do I deal with contamination OCD? Exposure and response prevention. It's really, we want to take all the fears or all the compulsions that somebody might be doing. Am I washing multiple times a day? Am I asking for reassurance? Am I avoiding? I usually start with there. I say write down all the compulsions you're doing and work on them, sometimes one by one. I'm only going to wash my hands before I eat, after I use the bathroom, and if I physically see dirt on my fingers. Might be a good guideline. And be willing to risk the what ifs. That, but I don't know. Just in case, I'll wash my hands. We usually don't do the just in cases anymore. And usually pick certain items. What are the things you want to get back to that you're avoiding? I want to touch my AirPods case. Okay, well, how can we get there? Some people are like, very slowly, I'm just going to tap it. But I usually say, I mean, that could be a long process of like, hey, 2 fingers, okay, 3 fingers. Like, I usually just say, just go for it. The anticipation is going to be worse than the actual thing most of the time for the exposure. And so we usually say, if I felt like I'm going to get sick because of this, or I'm going to feel gross, that can often be a feeling of contamination, then I'm willing to sit through that feeling and risk it, but not look for symptoms of like, okay, am I going to get sick now? Am I going to get sick now? Because that's the compulsion. We essentially just want you to start living life again, do the things you want to do, not avoid, and be okay with the uncomfortableness. And sometimes we do get sick. Sometimes we do get dirty. But we don't look back and say, aha, it's because that one thing that I touched. Because that's the crux of it all. People make those connections. So we don't make connections anymore. We just say, oh, happened to get sick. All right, cool. Or it's been 5 years. All right, maybe I'll get sick tomorrow. Like, we've got to be okay with the uncertainty of it all. Well, as the storm is coming to a close, I just wanted to say, I appreciate Justin being here. Where are you at, Justin? Did you say at the beginning?
Dallas. Yep.
Yeah. And so what's your website? Do you want me to put your website on here for you?
Yes.
You got a really sweet blog. Like, this guy is like the writer. He is so good at this stuff. That's not my thing. But the way he explains things are like, it's amazing. And so I recommend going to his thing. I'm going to put that up here. Is that your website? Just Hughes.
That's it.
Super simple.
That's it. No, wait, that's my competitor. How dare you?
Yeah.
Who's that good-looking guy? Just in case Hughes.
Justin Hughes. Man, look at his blog. It's amazing.
I really appreciate it.
You know, and I know some people are looking for wherever the program is. That's where I have it. OCD and Anxiety Online. I think it's great. You know, but either way, anything you want to say, Justin, before we end?
Just so glad to be here. So glad that y'all are here. I just love the community, and it's a neat opportunity. Thanks, Nate, for all you do. And I can see through the comments so far just how much folks really care about and love the work that you're doing, which is awesome. And each person who's here too, sometimes it can be easy to see people talking in an expert way, you know, on a video and so forth, and feel any number of things. Maybe you feel encouraged, or maybe you feel like you're in a hole tonight. Well, that's okay, and you're not alone. Yeah. And hopefully we can cross paths again at some point, and/or there's many others out there who are just ready and willing to walk with you.
Mm-hmm. I like that you said that. That's what this is all about. You're not alone. So many other people are going through what you're going through, and that's not to diminish what you are going through, but it's to say, like, for you to even write a comment, some of these vulnerable things, like, you're amazing. And I know some of these people, we might have missed some of your comments, and please come back for the next one, because I want to make sure we can answer them for you. And so, all right. Thank you guys so much for joining, and let me know in the comments though as well, like, should I have Justin back on? Just kidding. Should I love having other people to kind of help with this. It's really wonderful. So, all right. Thank you so much for joining, and I'll talk to you again.
Thanks, everyone.